going to try to do is give you a little bit of hopefully a little bit of help for trying to take medication or even think about medication, or even for those that are actually non-prescribers, how you could suggest to people the medications that they may use. So we know that for all sorts of psychiatric diseases and all sorts of substance use disorders, there's a whole host of medications that can be used, and it becomes just like a mess trying to figure out which ones to use because there's so many choices, okay? And this is something that I have talked about before and referred to as something called functional pharmacology. In my world, maybe we have an argument in some psychiatric issues and some substance use. In my world, especially in pain, I don't treat the disease, right? I treat the symptom. That's pretty much it. And you could sort of make the argument in substance use that you're treating the disease process, how brain infection, craving, and all that kind of stuff. But much of it, you can think about it as symptoms still. If I give somebody a medication for a disease process that drops their function, that's a failure. If I give somebody something for pain, a neuropathy, or even for a mood disorder, if I give them 2 points of benefit in terms of their primary disease and 3 points of negative because of the dysfunction the medication causes, I'm not winning, right? And so that's why I call this functional pharmacology. I want to have things work not only just for the disease process and checking the box for, gee, I took care of the neuropathy or the anxiety, et cetera. I want to see what their function is, and that becomes, I think, central. We've talked already about the comorbidities, et cetera. We don't need to get into all that and how much there are in terms of percentages that makes us really high in terms of comorbidities. And the same slide of all the symptoms, which is this one I'm going to approach is going to help sort out in terms of just straight pharmacologic choice. So how to approach this, back to disease and function. The first thing is diagnosing what you have. Classic kind of thing. Is this a medical issue? Are we talking about hypertension or a cancerous process or excuse me, a pain process, an orthopedic process? What is the diagnosis? Make sure that you're checking the comorbidities. What kind of thing is also having to do with their anxiety, depression, potentially personality disorder, et cetera, et cetera. And then also medication reactions, which is, I'm really sorry, medication reactions. Medications are supposed to do A. They have a set of side effects, et cetera, that are B. But the reality is, most medications affect each individual in a quite unique way and in ways that you wouldn't expect. And so when I start thinking about medication reaction, I'm talking about the things that you really don't expect. And I would encourage people, especially prescribers, to be really clear about that. And for each disease, there's multiple medications to choose from. So how do you choose with a disease from the myriad of possibilities in terms of medication choice? And once you have the diagnoses done, I then turn to, so, of all those things, what's the thing that actually limits you the most? And literally, I'll sometimes, especially in the pain world, actually ask you the question. Right? You've got fibromyalgia, you've got depression, you've got a little bit of ADHD and some cardiac disease, right? As you try to move through your day, what's the thing that keeps you from doing what you want to do? Right? Is it fatigue? Is it anxiety? Is it pain? What is the limiting feature? Because if I'm sitting there just thinking about a single disease, I still don't have any idea about what their function is. I talk to my APPs a lot, my nurse practitioners and PAs. I want you to be able to ask enough questions where you can actually get inside somebody's shoes, look out their eyes, and see something. I want you to be able to see what their world is. And as soon as you do that, it starts becoming clear what helps and doesn't help their function, what kind of things actually limit them, and then you target that, right? Not the thing that's not their pain and trying to treat a pain score, you're actually trying to treat what actually keeps them limited. And then treat with a medication that targets a disease that is most limiting the function. And this is the other part that is added in here. We'll get into this all in detail. I give them a medication that's going to optimize their ability to be in the world. If you're really tired and I'm trying to treat your neuropathy, I'm going to give you something that's going to not make you so tired. If you're really too jacked up and can't sleep at night and I'm going to treat your neuropathy, I'm going to give you something that's going to make you tired. Right? In other words, I'll try to optimize what your body can do. If you're too jacked up, I'm going to try to find something that's going to treat the disease and have a side effect of helping you relax. Or if you're too depressed and on the couch all the time 24/7, right, and I'm treating something, I'm gonna try to choose out of all the medication that will get you off the couch, okay? And so at the end of the day, it's look at the disease, right? What's the thing that limits them the most? And how are they doing? How are they moving? What are they doing? How can I actually help manifest and bring forward a more optimal kind of somatic, physical, emotional energy to actually be in the world in the first place? So in a little bit more detail, find out what is the functional limitation etiology, right? What is actually keeping them from functioning? Is it their pain? Is it a physical condition? Is it a psychiatric condition? Is it depression, anxiety, et cetera, et cetera? And also into the pharmacology, is it a pharmacologic issue? Now that they're taking their gabapentin for their pain, talk about gabapentin, are they so sedated and gaining weight that they're on the couch or asleep 12 to 14 hours a day, but their neuropathy is so much better, right? Not functioning at all at this point, and that becomes unhelpful and counterproductive. And you want to be clear about that. So the other thing is, I'll get into this in later slides, so I'll leave that alone for now. So when you do an assessment, it's kind of classic stuff. Do a normal workup, H&P scales that you can do for anxiety, depression, mood, pain, et cetera, all very helpful. But again, sometimes be careful about not treating a number. Again, try to remember that these scales can be helpful and give you cues about things, but if you're not sure, drill back into it and look at their function again as much as it is the scale. And clinically, to even try to determine function, I will very clearly ask them, especially in the pain world, how long can you be on your feet until you must sit down? Right? I don't mean until you hurt, until you want to sit down. How long can you go until you must sit down? Or for anxiety, how long can you be out of the house until you must hide? Or depression, et cetera, et cetera. Find some tools and some questions to figure out what they're really, really doing. Another one is how long can you sit until you must get up? Another one I use a lot is what room in the house do you spend most of your time? You'd be shocked by what the answer comes up with that. People are spending 90% of the time in the bedroom. Oh, right? So do you have a TV in there? Do you take meals in there? Do people come in and visit you there? Do you isolate in there? Why are you in your bedroom all the time? And you start exploring, kind of seeing what their world really is, or how much they're actually getting out. Try to see if you can actually get a very clear sense about what their function really is. And out of each one of those, if you can't walk any more than 10 minutes, why? What is it? I thought it was going to be your back pain, but actually you say your legs start to feel so fatigued, or you just feel so fatigued you don't want to, or you're too anxious to stay up because people are in the living room, you go back to the bedroom. Oh, you were here for pain. You got an 8/10 pain, right? But the thing that's keeping you in the bedroom is your anxiety. Why would I focus on the pain? Right? That's what I'm hoping you to do. Why aren't you out of the bedroom? Why aren't you walking, sitting, etc.? What is the thing that actually keeps you from actually doing the things we're hoping you to do? Medications. Again, all the medications that we use have textbook responses and also textbook side effects, but they have incredible impact, uniquely and specifically to some people, and I want to be much more clear about that. Because it's asking somebody, are you taking your meds? Yeah, you are. Taking the gabapentin? Yeah. Taking the Lyrica? Hopefully not at the same time, but yeah. Right? Are you taking the SNRI? Yeah. Not asking, how's your mood? What did it do to you? Did it affect your sexual function? Did it affect your sleep? And did it make you have more energy? Did it make you have less energy? Right? And every person will have a very unique response to that, and sometimes it can be very surprising. And also how you actually taking your medicines. This is something that actually is a very nice cue for what the medications are doing. So you have somebody, my classic example is like oxycodone. So how are you taking your short-acting oxycodone? Well, I'm taking it to understand the people, but if I was taking oxycodone on a PRN basis, right, I wouldn't just be taking it four times a day, every 6 hours, right? I'd be taking it when I hurt the most. I'd forget it, right? I'd take it on the days I didn't work or did work, right? So, and this is where I do my previous slide deck, this is where I do the normalization. You not taking it exactly like it says on the label is normal, right? I wouldn't take it exactly like it's on the label. If you tell me how you take it, and I can help you with the things that it is or is not doing for you. So just tell me how you're really taking it, right? My classic example is, well, I take 3 in the morning and 1 at noon. What do you mean 3 in the morning, right? It gives me energy.
Yep.
It wakes me up. It's a thing that I can do to get out of the house. Oh, it gives you energy. Yeah. And when you're short, why? Because I have to take a 5th one at night at 4 when the kids come home. Oh. So now you're out because you're using it for energy to actually stimulate you to get things done, and that's why you're short. That's why you're overusing. The reason I want to know that is then it teaches me, oh, this is what you're doing, this is what it does to you, and I can help your energy. I don't want you to take oxycodone for it. I'll give you bupropion. I'll give you individual Provigil. I'll make sure you take caffeine pills if you don't want to do that, whatever, right? I can help with your energy. Now, if I can do that, can I get you off this other thing that I'm doing, right? Where that's less functional for you. And so make sure you really know exactly why they're taking it, because that'll teach you what some of the effects are. They may take it all at night before going to sleep, so they can't sleep, right? And also then, like I'm just saying, look for the hints about medications to make sure that if they're actually misusing, you know why they're misusing. And notice the very bottom line here, I have really focus, especially with opioids, right? Because you're going to be dealing with the docs sending you people that they're going to say are substance use disorder opioids, because they're misusing their meds all the time. What does that mean? Well, they're short. I've been trying to help them, but I keep increasing the dose, and they're short by 20% every month, and they have substance use disorder. That person doesn't know what the definition of substance use disorder is, right? They've had a gut check, and they're upset that they're being short. But notice that 80% of the misuse of those meds is for something we would want to treat anyway. 80% of misuse is for pain, tension, sleep. What's the one they put on here? 80% misuse their meds for something we would want to treat. Right? That's how they got substance use disorder. It's like, why are we doing that to them? If you get them to talk to you about that, right, then you can actually help them. So why are you misusing? It gives me energy, it helps me sleep, it helps my anxiety, it's an irritable, it's a mood stabilizer, it's a mood enhancement, whatever. Let me help you with that. But again, that comes from normalizing and being curious about what happened in the first place. So unexpected responses to meds, just like I talked about. In substance use disorder, you can have things that are helpful for the symptom and deleterious for their function. I'm not taking care of their underlying disease process, I'm taking care of symptoms. If my fix or help of their symptoms makes their function worse, I'm not in. I'll go to something else, okay? And those atypical reactions or, more difficult functions, I have people on buprenorphine that are incredibly sedated by buprenorphine, right? I have people on buprenorphine that are so jacked they can't take any more than, half a milligram twice a day. They can't sleep, right? It goes both ways. And if I think they're being non-compliant, I have to realize what is the problem in the first place. And those things can be surprising, but that happens across all meds. Every med can do so many things. So look at all the meds used for substance use disorder, all that you use for mood, all you use for pain. And the classic think that certain sets of that all heroin addicts are nodding. No, folks. We've got a guy he's been working his hump off. He's a heroin addict from long, long ago, and he's seeing me now, and we're giving him buprenorphine. He's in the community, and he's doing great. And I was drilling into his use, and he said I was doing horrible. I couldn't do it very well, and I started using heroin in college, straight A's. Totally took care of my concentration, I could do things, never got tired from it, always got a little energy from it, did great. Realized this guy's got ADHD, and he was using his heroin for the treatment of his ADHD. So I said, wow, your friend, were any of them nodding? Not a single one. Right? We all had this group together, there was like 5 of us, so everyone of us got stimulated on heroin. And we used it to actually get through college, do well, etc. Right? People expect everything to be nodding. Not nodding. Right? So be careful about your assumptions about what medication is going to do. And it goes the other way. There's some people that take stimulants that are tired of them. They get sedated and they crash. Right? Anything can do anything. So be curious about it. Oh, generic medications. OMG. So if I have somebody who's really stable on things, and they've been stable for a year, same concoction, same protocol, they're working, etc. So they come in. The last month, man, I have not been able to sleep, my pain's horrible, my mood's horrible, whatever. You go through all the meds, you try something over the counter, you try some new concoction, that you got off the internet, somebody else can do that, no. Did your Cymbalta change color? Yeah. Again, how did that happen? About 6 weeks ago. Yeah, exactly, right? Did your oxy change? And personally right now, I'm confused about Subutex. Right? I've had some responses from people with Subutex. I'm going, I am not sure there's much why. Because I'll switch back and forth, and it doesn't have expected response. And I'm kind of going, part of me is wanting to send it off to the lab and say, could you tell me what's really is? And how much is in it and what the secondary byproducts are of this, because it's not looking good. So, and I go back and forth about this all the time, but do not be surprised by generic changes. They can be incredibly powerful and really quite shocking. So my classic thing, people have heard me talk before, things that people don't usually understand. We just got the article all written that's coming out. There's no literature, literally, that I've seen in the world from that can help me, right, with opioid stimulate people. There's one study to look at a bit which had 20 people, but in my world, I started realizing about 10 years ago that opioids stimulate some people, and they can cause them to have decrease in sleep, irritability, racing thoughts, physical agitation, distractibility, impulsivity, to the point where, in a certain subset, they look like horrible personalities, and they meet criteria for irritable mania. Irritable mania. That's the group that gets opiate-induced hyperalgesia. Right? But they are completely whacked on opioids from a stimulated sense. And so just be alert to that. It does exist, as you can see from here. In my clinic, I've crunched numbers out of a good number of people, and about 24% of the people are stimulated on oxycodone. About 9% of people are stimulated on morphine. That can switch. Some people are stimulated on morphine and are also some of the higher stage agents. And we'll get into that in a little while too. And the reason for it, lots of possible etiologies. Again, I talked about OAH. Here's the only other study that I've seen, at CDC 2011, that talked about energy from opioids, and this is pill addicts. It was 12 men, 12 women, and they said, what about this pill? What was the quality of this medication that got you pulled into it in the first place? 100% of women and 80% of men said energy. Right? So if you're looking at somebody who's got higher risk of sitting in front of you, you're anxious about them, you're giving them whatever, and this is the only people I've seen actually having substantial addiction issues with tramadol, they've been jacked, they've been stimulated on. And that becomes its own issue. So just realize that that's a marker. It doesn't mean that if you're stimulated, you're an addict. No. It just may increase your risk factor some, but don't be surprised by the atypical reactions to medications. So choosing meds, back to that topic, right? So now you know what the functional limitation is. You know that there's an atypical potential medication reaction. You've got that sorted out. How do you choose the med? Right? Now that you've got their symptom set sorted and what they're currently on sorted, how do you choose adding or not? Right? And what you do is you, again, target the disease that's most functionally impairing. And many meds will treat more than one disease, but which one actually is going to be the most helpful? Again, I want to be able to optimize their function, what I call optimizing somatic energy. I want their bodies, their psyches, to be able to enter the world in as clean a way as possible. I want them not to sleep too little. I want them not to sleep too much. But it really is, when I start thinking about medications after going through this, they're literally the amount they sleep in a day is one of the primary markers I use for which way I choose meds then. Are they too jacked? Are they too sedated? Right? And that helps me determine which way I want to go on meds. How do I determine that? Simple, add up the amount of hours of sleep. It's very, very simple. It's shooting for 8 hours, kind of, you would think normative. Some people don't have an 8-hour normative, they never had, they're 6-hour sleepers, they're 10-hour sleepers. You have to calculate that, figure out, before all this happened, how were you sleeping? I always slept like this, right? Okay. And were you depressed? No, I wasn't pretty depression, so what do I do? Okay, then that becomes their normal, so just realize that. Again, when I try to sort out their sleep, I go through sleep in an incredibly specific way. Now, people who have sat in my room know that I kind of go, I go into that in some detail. So I will literally say, okay, what's your bedtime, what's your target, and then when do you go to sleep? Well, you either go to sleep in 10 minutes, 30 minutes, 60 minutes, 2 hours, whatever. And my first question is, so what are you doing between bedtime and sleep time? Are you really trying? Or on your phone? Are you playing? Are you eating? Are you fighting? What are you doing? Give me a sense of that. So you finally go to sleep. When is it since you first wake up? Whatever, 1 hour, 2 hours, not till the morning, right? If you do wake up, why? Right? Did you essentially rebound out of your sleeping pill? Did you have pain? Right? Did you have anxiety attacks? Did you have a dream? Whatever. Why did you wake up? And if you are, how long you left? And if you're awake for X amount, because 70, 80, 90% of the people that are in bed at night watching the clock and not sleeping, right, have normal sleep studies. Right? So if they're laying in bed, I just kept tossing and turning. I was just making sleep all night, right? But are you out of bed? Never. right? How do you know you're asleep? I'm not asleep. I just see the clock, right? Well, that's not going to convince me that you're not asleep. So I want to be careful about giving anybody a sedative at that point, right? And then if you do wake up, how long you have, etc. And then when you get out of bed in the morning, okay, do you feel rested? And then do you nap in bed? And you take all those little pieces, right? And what's the added amount? If it's 8 hours, 7 to 9 hours, I'm in, but it's a total amount. It can be all broken, but they're still getting 7, 8, 9 hours of sleep. Some people, we'll get into in a second, are sleeping 10 hours. Am I going to give them a sleeping pill? Probably not, and we'll get into that. But many people come in and say, my sleep's horrible, I can't get to sleep, I can't stay asleep, they're just screaming and yelling. And one example of horrible sleep is they come in, their bedtime's 11 or 12, they do not initiate till 1 o'clock, wake up at 2 o'clock, right? Later stages of sleep, they go back to sleep again in 30 to 60 minutes after being up within a couple hours. And up for that period of time, do that 2 to 3 times, and then they're up in the morning, they get a total amount of sleep of about 2-3 hours. Really, when you add it all up, they're not sleeping, they're not napping, they're not sleeping. Their somatic energy is way high, we don't know why yet. That's a horrible sleep pattern. The other horrible sleep pattern is staying to bed at the same time, but they don't get to sleep until 5 o'clock in the morning. Okay? And when they get slept, they go to bed at 5 o'clock, but they've been up watching TV, hanging out, right? And then they wake up at 7 o'clock for the family, go to bed after that, sleep until 3 or 4 o'clock, and then they're up for the family and up for the evening. And they're saying that, hey, I have horrible sleep. And it's like, no, dude, you're sleeping 8 or 9 hours, right? You're in the wrong time zone, right? But 8 or 9 hours. Under these, at 11 o'clock, they took their Ambien, Trazodone, Seroquel, right, on top of a drink or something earlier in the night, and they're hanging out, a little bit whacked to the evening, right, watching TV and hanging out. And it's like, first of all, your sleeping med is not working, so we're going to stop that. Number 2, I think you're hanging out, and I'm not going to give you a sleeping pill. Your sleep's fine, right? Long time, but it's fine. And if you want to do that, that's okay. It's going to mess with your relationships, but I am not going to give you a sleeping pill for this. In fact, I'm going to take sleeping pills away. And what I do is I go after sleep debt. Right? So the thing that makes us sleep at night is how much, essentially the way I talk about it, how much we burn our candle in the day. If you're not burning your candle in the day, there's no need to make it up at night. Right? And so what I'll do long before giving somebody sleeping the pill is I will drive their energy in the day. I'll take away sedatives, especially if they have the 8 to 9 hours, but they're sleeping through the morning. Take away sedatives, take away the things that are not functional for them, be it gabapentin or whatever, right? And then give them something in the morning if I need to get them to be energized, and they will sleep better. Right? So instead of hitting you with a brick at night to knock you out and giving you a hangover in the morning, I will make you burn your candle in the day, and your sleep totally changes and actually sometimes condenses. And that's my story with them. Most people can buy, and also they end up being more functional, right? But now we know how much somatic energy do you have. Are you above 8 hours of sleep? Are you below 8 hours of sleep? Okay? And if you have too high of energy, what are kind of the manifestations of that you can see? Again, they're not sleeping very well, they can be anxious, irritable, they tend to be ruminators, they can have more reactive mood and impulsivity, they can have spasms, and many times they'll talk about their minds being too full, not too empty. If I'm confused about somebody, I'm wondering, do I think this is really an anxiety process or a depressive process? And that's not a great Uber marker, but I'll ask them, is your brain usually too full or too empty? And people kind of give you a cue that sometimes you can run down, it can be helpful. And the reasons for this kind of level, high somatic energy, can be pain, can be psych, anything, can be substance use, can be pharmacology, atypical effects, etc. Can you try to sort that out? And if you can, then go after that entity, because that may be something that you're taking them off of something to get their somatic energy straight, rather than starting them on something. I'm giving you oxycodone at night. I didn't know it's actually for you it's like cocaine. I probably need to take you off the oxycodone, not give you Ambien, right? And that kind of process over and over. And then behavioral manifestations, low physical energy. They tend to sleep more than 24 hours, depressed, cognitively dulled. They tend to have sleep rotation where they're actually going to bed at 2 or 3 o'clock and getting up at noon to 2. Right? They tend to do sleep rotation. They have more falling, low energy, low concentration, etc. And the etiology is back to the exact same side. It can be anything that will actually give you low energy. So how do you choose your meds now? We've gone through what's the disease, what's their real function, what's the really doing, medications really doing, and you have their energy. right? So how do you choose a med? Because sure, there's a whole pile of meds for whatever disease you're going to be shooting for. And I would go after the depends on the disease you're treating, right? But for pain and mood, you're going to be into things like if you can do one medicine with numerous effects, they can do what I call twofers, that'd be great. And there's a couple examples there for pain and mood, like duloxetine and milnacipran, or mood and ADHD is bupropion, etc. But if they have low somatic energy, right, then give them a med that's going to give them more energy, and that med's going to treat the disease you're targeting, but it's also going to have a side effect, tend to, of energy. Okay? If they are high energy already, then I'm going to still know that I'm treating a particular disease, but I'm going to give them a medicine that's going to tend to give them lower energy. So even though I'm staying specific to the disease with my pharmacology, I'm going to choose a pharmacology about whether, now that I have that group of meds chosen, am I going to use a med that's going to give them energy or make them sedated, depending on what I'm treating. Are they too high energy? I'll make them more calm. If they're too low energy, I'll give them more energy by choosing the right med. And again, one thing at a time, et cetera, et cetera. So, choices. You're going to be doing anxiety or depression treatment. You want to check out antidepressants. This is what I see as the medications. Please, psychiatry, jump in, as always. This actually looked into this in research once, and it worked out pretty well on looking at all the effects of all the meds. But if I'm going to give them an antidepressant, right, and I want to give them the most energizing antidepressant I can, I'm going to start with Wellbutrin. Maybe Fatsima. Fatsima is also good. It's milnacipran. Legal milnacipran. So this person is depressed or anxious, and they have too little energy. They're sleeping all the time. And I want to treat this disease, but I want to choose something now that's going to help also push their energy in the direction I want to push it. So if they're sleeping all the time and they're depressed, I will choose something off the top. I will give them something that's going to tend to give them energy. If they're on the bottom and they're sleeping all the time and they're too stimulated and anxious and agitated, I'm going to start from the bottom, right, and give them something that's going to be more sedating. That's how I choose a med. Rather than looking at this whole pile of meds and going, OMG, what med do I choose? It starts to kind of organize your brain about what you can actually use and what would be most effective. The other thing is, notice, it's certainly the most stimulating, but also if people are really not sleeping at all, right? When did they start their Wellbutrin? Right? When did they start their Fatsima? Right? That may have been the thing that actually caused them to not be able to sleep. So that's the other side of the equation. When did they start it? What's the medicine doing? When did you start having your symptoms set? Okay? And that will also, maybe they need to come off of Wellbutrin because they're unable to sleep. So again, when you think about these meds, these at the top of the most stimulating can cause high somatic energy, and you use them if they have low somatic energy, depending on which way you want to drive. Same with the bottom. And again, in general, medications that tend to stimulate you tend to make you lose weight. Medications that tend to sedate tend to make you gain weight, and it's kind of a loose and simplistic way of talking about it. So it's the same thing in my world. This is the list of opioids. Right? Oxycodone, hydrocodone, and fentanyl tend to be the ones that I find to be the most stimulating. And this is purely a practice life, way practice life. The morphine, hydromorphone, and methadone tend to be the most sedating. I have people that have been completely energy neutral to all meds take methadone. Classic is 65, 70-year-old lady, tried her on methadone after doing all sorts of things, trying to help with her pain, and she was so activated. Within 24 hours, she was like swinging from the chandelier. So it was just outrageous. And I've never seen somebody so activated on something. It was just nuts. She loved it, kind of. But it was just like, OMG. I mean, so it can be any reaction to any med. You have to check. Don't, again, believe what you think. Right? Back to curious, back to being sorted, trying to sort it out, etc. Anticonvulsants. Right? Same kind of thing. That's why Lamictal is one of my favorite anticonvulsants. These slides are all probably going to be available to them, right? All slides are available. So,
Where?
To me, $29.99. So, sorry, I had to. So Lamictal is one of my favorite drugs because it tends to give people energy. Not everybody, but it tends to, in a group of medications, that tend to be really sedated, right? And if you, again, want to make sure somebody's more sedated, you give them Topamax. And yet, I'm not sure if the psychs have seen it, I've had 3, 4 people that on Topamax get really manic. I mean, just in their irritable manic. They are not happy. Sometimes that happens. So again, back to every minute, check it out. Right, check it out. Stimulating agents. So this is what's the most stimulating of the stimulants? Right, they're all going to be stimulating, unless they have a counter odd reaction. Some may be sedating some people. But the classic stimulants are the most stimulating. The bupropion at the bottom is pretty stimulating. Sabella, etc. Provigil, Nuvigil is now modafinil. People use modafinil? It became generic about 1.5 years ago, something like that. Great drug, very helpful drug. $30 cash pay, good RX. It's a very helpful one. Antipsychotics, same kind of thing. Right, which are going to be most stimulating generally, which are going to be less stimulating generally. And again, psychiatry is not anything like. And so,
do you have Vyvanse that was stimulating?
Yeah, because Vyvanse becomes, I use dextroamphetamine and Ritalin and methylphenidate as kind of the 2 primary compounds and all the derivatives. So Vyvanse is kind of the derivative of dextroamphetamine. No, they don't. I mean, I love Vyvanse because it's a delivery system by which the liver actually metabolizes it and turns it into the stimulant. Very smooth delivery system. And because of that, it doesn't have much of end of dose issues where they don't get irritable, tired, whatever. And the onset is very smooth and good, and then back down the other side. It's a very good drug. It tends to be in the dextroamphetamine world. It's clearly a stimulant. As often can you use dual-acting agents? Okay? For pain and depression, back to the same thing, duloxetine, Fatsima, and in the pain world, it's actually called Sabella. That's milnacipran rather than levomilnacipran. Pain and anxiety, gabapentin, and again, pregabalin is good for anxiety. Lyrica is very good for anxiety. Some people, gabapentin works well. Substance use disorder, certainly I use a lot of buprenorphine just for pain. Mood instability and pain, you can see those, irritability, TBI and ADHD, et cetera, et cetera. The more you can actually use twofers, the better. You're using them with single medication, but again, they can have their wild card reactions. Does it work? Guess when my articles are finally coming out over the last few years, this one should be out in the next 6 months or so. So this type of medication management we use in the high utilizers in the Duke system, and we found that the top utilizers of 570 people we could actually look at, the top utilizers are 20%. That's right. Other 570, we talked about the top high utilizers are all high utilizers, but the top high utilizers are the ones that use the most funds, cost the most money to the system, the top 20% of that 570. And then we looked at those and tried to figure out, did we do anything? It turns out the inpatient charges dropped by 46% in the top 20%. They dropped by 50%, 50% in the top 10%. And the total of this in our practice is about $3 million plus a year that we save the Duke system by using this kind of program for that high utilizer group. And so it has effect, it works, and it's, again, $39K per person per year. It's not a small amount. If you can start doing this kind of stuff, I think you'll have positive outcomes in your patients. But the biggest thing is, what are you treating, right? Do they have any energy? What are the effects of the things that are really, what are the real effects of the things they're already taking? What do they have for somatic energy? Put that together and choose the med that's going to help them normalize their somatic energy and help them maintain their function. Okay? We can go through cases, but those are all pain-based. Please.
How long for your patient?
What is that?
Seriously.
3 days usually. No, that's an excellent question. So far I've been given the privilege there of literally doing an hour to an hour and a half intake. Right? It is not small in the pain clinic. And my rechecks can be 45 minutes. And so they've given me the privilege of doing that, which is great, because it does take that long. I'm not doing therapy. There's none of that. It's really, even doing an intake in the high utilizer pain group, I am really hitting the buttons all the way through. So I want to, everything having to do with their pain, everything having to do with their mood, all their genetics, and the parents, like what's in the family history. what's their substance use pattern in detail and why, what's the sweet spot for you, what did every medication do, right? And then after doing that for 45 minutes to an hour, you're gonna have a sense of their personality. So I can say, you're gonna be impulsive, you're gonna be irritable, you're gonna want this, and I'm not gonna be able to do that probably, and you're gonna be angry at me probably for A, B, C, X, Y, Z, right? But we're gonna be able to do this and get through it, it's gonna be okay. And also educating them, especially in pain patients, and not substance use so much, but certainly in pain. I start off by telling them, the life that you thought you were gonna have is over, right? Your car is a junker, all right? Your body as a car is a junker, right? And I can't fix your car. Right, you got quarter panels broken, the window shields are broken, the mirrors are all gone, you're blowing smoke down the road. Right? I can't fix that. If I try to fix that, we're going to kill you with meds. If you try to fix it, you're going to kill yourself with surgeries and interventions, right? I can help your pain 30, 40, maybe 50% max, and that's it. That's all I can do. I can help you get that junker down the road there, right? And so I feel like I can help you, I really can, right? But I can't fix your car. And so if that's the agreement that we have, that also becomes a metaphor. I with them all the time. The gabapentin, you got to get our foot off the brake, right? Wellbutrin's going to put the foot on the gas. Not going to change things, it's going to get you going down the road more. Because right now you're partially garage all the time, too. They got to get you going. Okay. Other questions at all?
You can do the cases if you want. You have 3 more minutes.
They're paying. Yes. We'll see how they do. So 48-year-old male laborer, lumbar degeneration, chronic pain. Out of work on STD, short-term disability. That was due to an increased pain following a lift and twist injury at work. PT has been started. Pain increasing, depressed, anxious about career finances. Low energy due to difficulty sleeping, pain and rumination, depression, and pain. On low-dose oxycodone, QID, PRN, and HS, Remeron, mirtazapine, not working as well as he wishes. Right? So what would you do? Look at that. How would you sort out which medication you would even come near? One is we don't know what the oxycodone's doing. Oxycodone could be stimulating, could be sedating. That'd be important to know. If you're going to start something, what would you do in this person? Pardon? Duloxetine would be very good. That would be a very good choice. I find duloxetine not as energizing, usually, but it actually covers 2 bases. They're not wrong at all. I think it would be a very reasonable thing to do. Completely reasonable. Sorry? I would. I would probably start Wellbutrin. And certainly the pain is present. The pain is an issue, but when I try to get them to actually be more functional, but the idea that duloxetine is totally fine. I mean, it really is. And truthfully, it probably will depend on my mood. It's like, it's not, because both of those are kind of similar. And duloxetine sedates 10% of the people. Right? I find actually 30-40% of the people get a little bit of energy from duloxetine. The people that actually get sedated from duloxetine, I find, tend to be the ones that gain weight on it, which is not horribly common, but it does happen. And so it's a very good try. It would be a very reasonable thing to try. But I would think about Wellbutrin also. In this step, right, if I did Wellbutrin and it didn't work, I would go to duloxetine. That'd be the very next thing that I would do.
So when we see patients in psychiatry without the pain, somebody who would have prominent anxiety, we would choose something like duloxetine or SSRI versus Wellbutrin, just because of the anxiety. To what extent does that factor into the pain practice? The prominence of anxiety in terms of driving selection of antidepressants?
A lot. Yeah, no, it really does. So anxiety, it depends on, again, how much I think that's actually going to be impacting their function, right? Because if they have some anxiety, that's what they told me. They have, maybe they're doing a little bit of checking, they're a little bit of ruminator, but it's not the primary thing driving their dysfunction, then I would be going after that. And also in my practice, fibromyalgia. The article came out last year, 50% of people with fibromyalgia have ADHD. Because there's something about the sensory integration piece of it that I think is valid. And so I would also, with the anxiety, say, are you ADHD? I go through that whole drill and see if part of the anxiety is because of an ADHD-like quality, and I would then still go after something more stimulating, right? And then assuming that their anxiety is going to get better with the ADHD treatment.
If we're going to start duloxetine, are we going to take the
For myself, no. Right? I think serotonin syndrome is a real thing. I think serotonin syndrome is over-feared and underdiagnosed. My psychiatrist checked me on this again. I think much of the emergency room issue of that was serotonin syndrome is a norepinephrine reaction as much as anything. Right? They're agitated, they're anxious, they're sweaty. There's no muscle tension. There's maybe the pressure's up, maybe not. Right? But it's that they just have this agitation. The ER doc sees 2 minutes and goes, you're on tramadol. Gotta stop it. And it's like, I'm not sure. I have not seen a whole lot of serotonin syndrome. Psych, how many serotonin syndromes?
Yes, sir. And serotonin syndrome is way more reported than actual. I mean, if you look at published studies, there have been published studies of 200 to 300 cases overall. So most of the time, it's taking too much of the antidepressants, producing side effects which are misdiagnosed, or sometimes the drug interaction, but not the say.
Thank you.
Yeah, it usually takes 3 different serotonergic medicines to get
Yeah.
serotonin.
Yeah, sometimes my medication lists are really horrible. They're on tramadol, duloxetine, and something for their migraines, a triptan. The pharmacist is like having a coronary.
Question,
Sure.
would you change his pain medication?
Potentially. Yeah, I certainly would. If I found out that the oxycodone was sedating as a primary thing in here, right, I would go potentially after that, even initially. Right? And yes, I would think about
What
that.
would you change to?
It depends on the situation again. If I found that the oxycodone was sedating, right, I would probably try, truthfully, in my current world, I would probably try Nucynta, right, tapentadol, if I can get it. Anybody heard about Nucynta? Yeah?
Very approved easily.
Pardon?
Insurance companies.
Yeah. Yeah, no, actually, what's surprising, that people are getting smarter. The insurance companies are getting smarter. There's actually been much more of it coming out than previous. Also, our list of meds is so long. Have they tried? Yes. That's right. So that's another thing. But Nucynta is tapentadol. It's a Schedule II substance. Very briefly, you'll see some of this coming in on all the opiate. Give me a high sign when I'm done, okay? Okay. Opiate world. At the very top of the 10 scale of opiates, when I talk to my patients, I make it simple. Opium is 10, right? And a 9.5 is heroin. And a 9.0, this is exactly how I describe it, is oxycodone, fentanyl, hydrocodone, everything. They're all heroin-like. Right? They'll mess with your immune system, your hormone system, all of that. So in the middle live what I call 3 safer kind of drugs. The bottom of that pile, least effective, is still helpful for some people, is tramadol, Ultram, which you've probably all heard about. The next one up is Nucynta. Nucynta is tapentadol. It is a full new opiate agonist, a Schedule II substance, with an activity at the mu receptor 150th, 150th of morphine. Right? And so people don't die from Nucynta. Right? It also has a norepinephrine function. So that combination of opioid and of norepinephrine, right, leaves you, right, with something that actually works. So 50 milligrams of tapentadol is clinically equal to about 10 milligrams of oxycodone. Right? Incredibly safer. And so I'll tell people all the time on that. I'll start Nucynta. If I can't get it, and a new start, or many times even a change, is next go to buprenorphine products for pain. I'll do Butrans patches or Belbuca patch inside the cheek, both for pain. Medicaid covers the Belbuca inside the cheek with 1 or 2 trials. Or I'll literally give them Suboxone Zepitex, low dose for the disease of pain. Right? And that can be really helpful, long before I get into full agonist opioids. If I was stuck in full agonist opioids with this, I'd probably try Pan oxymorphone next. It has a chance of being the most stimulating, and then I'd just kind of bang around, so I'm not sure at that point, what they would be. Yeah.
Do you find buprenorphine helping with mood?
Yes. Yeah, buprenorphine is shocking. The first time I tried, when Bill Buca first came out, a cocaine addict that had pain, a sickle cell guy, and he was such a hoot. I really like the guy. But I started him on Belbuca, and he could not take any more than half of a 75 mic patch. He had been in the bedroom, tired, depressed all the time. He was hypomanic. His wife came in, this is great. He felt great on it, but it's like, and then it slowly wore off. It's interesting, it slowly wore off and hasn't done that as much after the first 2 to 4 months. But it can be really stimulating. Buprenorphine is the only opiate I've seen that actually has a warning of insomnia.
How often do you see like a combination, like it's a bipolar and
Yes, and the first thing, truthfully, going back to a previous topic, first thing I do is actually check, do they really have bipolar disease? Right? Because they're gonna have the diagnosis of bipolar, because the ADHD is gonna make them sometimes an irritable, impulsive, mind racing. They're gonna report that to somebody, and somebody's going, oh, it's bipolar disease, and that carries through in their record, and it's like, have you really had a period of 5 days of sleeping no more than 2 to 3 hours? What do you mean? No, I've never had that, right? Oh, so I'd be curious about that. It's still possible. But ADHD and pain, really common. And also highly impulsive, hard to keep their meds organized, and they're, if you're asking somebody that has ADHD, and they're getting oxycodone and they're stimulated from the oxycodone, you ask them, does the oxycodone stimulate you? Nah. Does it make you sedated? No. Right? What does it do? It just makes me feel normal. Oh, and I see you're taking Adderall. Does the Adderall stimulate you? Nah. What does it do? It makes you feel normal. Oh. So that's how you metabolize the felt sensation of energy, because it helps your concentration. And you don't talk about it as giving you energy. Right? And I find that really common. And so if you're thinking, gosh, it seems like this may be giving you some stimulation, right? Have they tried other things? What cocaine do? Does cocaine really jack you up? Yeah, sometimes, but usually I just, good. Like, oh. So sometimes you can't tell. Any other questions?
How often do you see that when you treat the ADHD that it helps the pain?
Less than I would like, truthfully. But it does help with the anxiety. It does help with impulsivity, right? And it also gives them more function because they are somatically activated. Even though they don't see it like that, they do have more resilience, more energy, more capacity, and so that helps their function. But I haven't seen it do as much with their pain as I would like. So ADHD is kind of an interesting thing. It's the way I describe it. There's 3 components to ADHD. It's like too much thought, too much emotion, too much sensation. It's very common that people with ADHD pulling tags out of their clothes, taking the seams out of their socks, certain foods that they got to eat because they have sensory integration issues. And this article did come out and say fibromyalgia, central sensitization issue, 50% had ADHD. And it's, I think, in 100 years after I'm long gone, there's going to be a spectrum disease thing that we're going to discover. It's really going to be very interesting, but right now, not. Please.
In the limited time I have in a community-based clinic, how do you maximize what you can learn? How do you suggest it? I am in an integrated care environment, but I have people who are chronically ill at the same time who are also on a laundry list of medications.
And how do you do what with them? How do you educate them?
How do I maximize getting through that list to make sure I'm not seeing a contraindication of a med?
Oh, and also on a timeline? Yeah, really hard. Like you were saying, yeah.
Sure.
I clearly have the privilege of sitting longer. And so that privilege is eroding currently. You see me crying, just that. And what I've started to do, and I have to do sometimes, is single problem visits. And really drill down into it and have in my own medical record a marker next to the one that I drilled down into last time, so I don't get distracted by it. Right. I drilled down into your neuropathy last time and checked all the meds. We're not talking about it, but no, I'm trying to help you. We're going to go after the diabetes. We're going to after the something. Just calm down, stay with one, make notes to yourself, and come back. Yeah, because it's hellacious. I'm really sorry. Okay. Thank you all.
Thanks to Dr. Bracken. Very so now we're going to move cost effectiveness, and we're going to ask Dr. Eric Morse to help us with that. He's an addiction and sports psychiatrist, medical director of 3 opioid treatment programs, and program sponsor of Morse Clinics, which is probably one of the larger buprenorphine robot practices in North Carolina.
We can't hear you. The mic must be off or something.
Hello.
No.
I'll talk very loudly until the person with the lavalier comes up, or Paula to say, give our next presentation. He's an addiction and sports psychiatrist, medical director of 3 opioid treatment programs, as well as a large OBOT clinic as well, Carolina Performance. He's been a sports psychiatrist for North Carolina State for the past 13 years, worked with pro teams and leagues. After completing a residency in psychiatry at UNC, he did psychiatry fellowship at the University of Maryland. He, as I said, has one of the larger buprenorphine OBOT practices in the state. Eric?
So, thank you. I want to thank everybody here for being here, being part of the solution to the opioid epidemic. I think it's great that you're here. And I really want to thank the Governor's Institute for inviting me to speak this year. And today I'm going to talk about cost effectiveness. So we're going to talk about money. And it's somewhat uncouth to talk about money, especially in public, but unfortunately I don't possess a lot of couth. We'll do just fine. I want to tell people that we're going to stop at 2:30 instead of 2:45, like the program says. So we get a pee break at 2:30. You may not have to pee right now, but we are going to talk a lot about pee and the cost of labs. So you may get the urge. But you can't pee until 2:30 unless you're wearing Depends, in which case you go ahead and pee now. So this is also and be back early at 2:45. So that's not a 30-minute break. It's still a 15-minute break. It just got moved up 15 minutes. And that's because I only have 11 slides. So this is going to be the shortest talk. But hopefully it gets the point across. I want this to be practical, that you can use on a daily basis when you come across a patient with opioid use disorder. What's the most cost-effective way of treating it and screening for what you need to screen for? So let's talk about me a little bit, because that's really my favorite topic. So when I was asked to give this talk about cost effectiveness, I hadn't given this talk before, and I thought to myself, well, I'm not an expert. But, as a sports psychiatrist, I'm big on positive self-talk. So I'm like, well, dummy, yes you are, because you've opened 2 OBOTs, right? And I've opened 9 OTPs. So an OBOT is an office-based opioid treatment program, not a Suboxone clinic. I hate that term. So I offer buprenorphine out of my private practice, right? And I treat mental illness, okay? So you're not just coming to me for your buprenorphine, right? I don't like it when I see road signs saying Suboxone clinic, call this number. I mean, that was not the purpose of Data 2000, right? We're supposed to treat opioid use disorder just like any other disorder. We're supposed to reduce stigma, and not just compartmentalize people into a diagnosis. So I think that's really important. If you've gotten an X waiver and you're thinking about doing buprenorphine, running an OBOT, it's really just like running the rest of your practice. That's the way you should think of it. When you identify opioid use disorder, you're going to treat it like you would most anything else. But you want to be cost effective. I've never given a talk without saying I hate benzos. So I can't break that streak. I do like chocolate. So right now I own and operate 7 OTPs in the Triangle area. And we have about 1,400 patients in the 7 clinics. And it's important to try to keep your costs low when you're trying to keep your clinics open. And so I'm trying to be as cost effective as I can be. And then I also own and operate Carolina Performance, where we have 7 waivered MDs. Probably I asked everybody how much they've got, and so we're treating about 1,300 folks with opioid use disorder right now. So that's a good amount of people. And so I get probably 2 or 3 calls a day from somebody who is somewhat new to treatment, who says, I'm addicted to opiates, help me, what should I do? And so I ask a series of questions, and one of those questions, what can you afford? Is one of my first questions. That may sound sad, but it's extremely practical, right? Because when you're trying to decide what level of treatment you're going to use, there's certain things you want to think about. And the first thing is, all right, should this person be in an OBOT, an office-based opioid treatment program, or should they be in an OTP? So if, let's say they have Medicaid, right? It's hard to find an OBOT provider who takes Medicaid, depending on where you are. And if you can find that person, usually they have a wait list. So they may, in an OTP, an opioid treatment program, commonly known as methadone clinics, but I don't like to call it that because pretty much all of the methadone clinics in North Carolina offer buprenorphine. Okay, so I don't call it that, but some of you may know it as that. Most OTPs accept Medicaid, and their treatment's going to be completely free. So you want to be cost effective off the bat. I'm trying to get people into treatment and keep them there. Because the medical evidence is for maintenance therapy. It's going to be years of treatment. And so let's make sure you can afford it right off the bat. So let's say someone has no insurance and they don't have funds. Well, there's the SOARS grant, the State Opioid Response Grant. I don't know what the S stands for. Second. So, anybody who doesn't have insurance can go to an OTP and get free treatment right now. So that's huge. I think that's a big part of why Scott's talk in the morning, the first talk, where you're seeing less overdose deaths, is because people can get into treatment with access. And then if you've got private insurance, usually OBOT is the cheapest way to go, because the insurance may pay for your doc visits, and your insurance should cover your medicine. Another big barrier is transportation. So in an OTP setting, you're going and you're dosing daily. You can earn take-homes, but usually it takes a while to earn take-homes. With an OBOT, you can see a doctor weekly. And so if you're really having transportation problems, then maybe OBOT would be more effective for you. We're going to talk a little more about the costs of OTP versus OBOT. And then we're also going to talk about drug testing and what's most cost effective, and then HIV, Hep B, and Hep C testing. So let's talk about OTP versus OBOT in terms of you, the provider, and how much that costs you. Okay? So the startup costs for an OTP, the cheapest I've ever really opened one is it cost me about $150,000. So you're talking about renting space, upfitting it, putting in dosing windows. You got to get DEA approved cameras, and the DVR that comes with that, 2-ton safe. Methasoft, they have monopoly on software. You add all that together, the cheapest I've ever done is $150,000. OBOT, you need a desk and a chair, and probably any money. So it's a lot more cost effective as a provider. If you're already in private practice, you already have the stuff in your office, you have to do the X-waiver training, usually can do that for free. But it really doesn't cost anything to accept opioid use disorder suffering patients into your existing private practice. And then OTPs, you've got payroll. Love stimulating the economy, love hiring folks. But you gotta pay nurses, that's required. They're dispensing, administrating the methadone and buprenorphine. You gotta hire counselors, there's a 51 ratio in an OTP, so you gotta make sure you have, for every 50 patients, you need at least one full-time counselor. And that's true even if you only have 1 or 2 patients when you first start open. You gotta have to have front desk, you need security, you need billing. You also need a doc. That's sometimes the most expensive part, and I usually work for free. So there are a lot of payroll costs, and in an OBOT, there's just usually yourself. You might have a front desk person, I don't. I don't have a secretary, I don't have anybody else working, I'm just in solo private practice. At Carolina Performance, we're all in solo private practice, so there's no shared call, there's no shared liability, which is important. And that's just the way I like to keep it. And then regulatorily, with an OBOT, I mean, you have to follow the standard of care. But there's really very little supervision. You could get a DEA audit. I've been doing OBOT since before the medicine came out on the market back in 2003. And I've had 2 DEA audits in 16 years. And both were basically just give me your list of patients. How many patients do you have, and are you at your 30, 100, or 275 limit? So there's, regulatorily speaking, an OBOT doesn't have much at all. But an OTP, you're going to be reviewed by NC-SODA, Drug Control, DEA, CARF, DHSR, your MCOs. So you've got a lot more regulatory stuff to deal with. So, oftentimes I'll get calls from people who want to get into the space, right? I want to get into the market of treating opioid use disorder, because the thinking is there's lots of money in it. I've lost more money than I've made in it. But I don't usually help those people, because they don't really care about people. They just want to make money, and so I don't help those people. But when a clinician asks me, do you want to, I'm thinking about an OBOT versus an OTP, my advice is, do an OBOT, because your risk is so much less. And then once you get experience in this patient population, and you decide you want an OTP, you can then do that. It's good to work in an OTP before you decide to open your own. You decide if you like it. That's the other bit of advice I always give. And we talked about this. Medicare, starting in, I think, January, Medicare is going to follow Medicaid. And so if you have Medicare only, right now in the state of North Carolina, you got to pay out of pocket. And so that's going to be changing, hopefully. And commercial insurance, they very rarely will reimburse an OTP. And they'll very rarely reimburse the patient out of network for OTP services as well. It's rare. You have to really work hard to get that. And so what I charge, we're the cheapest in the state for OTP. We're $80 a week. And most clinics are somewhere between $80 and $140, just to give you a cost analysis. And so if you have private insurance with an OBOT, you got to pay for your doc visit. If they're in your network, if you find somebody in your network, you just have your usual copay, and then your copay for the prescription. So OBOTs are usually much more cost effective than OTPs in that situation. And we've already talked about what the cost is in OTP. So let's talk about urine drug testing. So I used to own a little lab. I closed it. And for a while there, you know, I could open some clinics with the money I was making, you know, running tests on pee. There was some gold in that pee. But rates were cut. Some of the standards changed. And so now I have to pay someone else to run our tests for us, which is fine. I mean, it used to be wink, wink, nudge, nudge. If you had enough Medicaid patients, we'll do your self-pays for free. Those days are over. Now, you know, and probably so, they're going to charge you for all your self-paid clients something. And that's negotiable depending on who you use and what kind of friendships you have. But in my office, I mean, the instant cut I buy, and I buy 200 at a time, and it usually lasts me a couple of weeks for between 7 OBOT providers. And it works out to be about $3 a cup. And so that gives you an immunoassay instant result, which you then can decide whether or not you want to confirm. You know, the cost of immunoassays, if you send it to a lab, they're usually somewhere between $4 and $20. That's the cost to run it. Someone might try to charge you more. Don't let that happen. And then mass spectroscopy, so your gas or your laser, somewhere between, can vary between $35 and $400, depending on how many substances you're testing for. That's a big question. So what are you testing for? And do you need to confirm when you get an instant cut and you get 14 different results? You know, which one of those do you really need to confirm? And so it's important to understand what it's testing for and what it's not testing for, right? So a typical 14 panel is going to test for pretty much everything except Clonopin, which only you're going to get about 20% effective testing of. And it's not going to test for fentanyl unless you have fentanyl in your cup, which isn't really commercially possible right now. You usually got to buy the fentanyl dips separate. So, you know, you have to decide, and what I do is on a patient-by-patient basis now. I've done a lot less mass spectroscopy tests now that it's costing me and the patient money. I've been doing less of them, but I do usually at least once a year spend the money for a mass spec confirmation to rule out Clonopin and fentanyl. If you're doing OBOT, it's helpful to get the Norbup, which is the metabolite of buprenorphine, to make sure they're actually taking the medicine and not putting a little buprenorphine at the end of their urethra. And you're getting, even if you're doing a really good observed urine, but not like microscopic observed, that'd be weird. You might be getting somebody who's clean and sober who is peeing out buprenorphine, and their screen on the cup looks fantastic. They're not actually taking any of the medicine, they're just selling it. So in those cases, I like getting a norbuprenorphine every once in a while. You know, probably helps me with the medical board too, to get a norbuprenorphine confirmation, which you can't get on an immunoassay. It's pretty complex, but the saliva tests are pretty vary in cost quite a bit. Obviously, you can observe someone's mouth a lot easier than you can observe their privates. Dried blood spot tests are becoming more popular. Those range from 75 to 400. And then your hair follicle tests, which give you a larger window of use runs between 65 and 400. HIV testing, you know, there's a number of screens. You know, it's $8 to $60 for a screen. You know, viral load costs between 40 to 85, and there's a lot of community resources and grants. You know, starting with your health department, asking, you know, how can I get this person tested if they don't have private insurance or Medicaid and they're self-pay? There's usually resources for them to get tested. So there's really no reason not to get them screened and treated. Hepatitis, obviously that's, you know, very much on the rise. I think, you know, Scott's, like I said, increased 360%. And you're going to see that particularly in folks who are having unprotected sex and using IV with their use. So, you know, the costs, a rapid screen is going to cost you somewhere between 10 and 50. Your viral loads are 90 to 200. If you're going to stage so that you can justify using the hepatitis C eradicating medicine, sometimes that's required by some insurance companies. That runs you about 200. And then your medication costs vary tremendously. What the real costs are and what they charge are two astronomically different numbers. Of course, there are R&D. Get your treat. It's real cheap there. And then your transplant costs. So I mean, obviously, if you're screening and you get it early and you treat it and you're avoiding the transplant, I mean, it's going to save. That's really the key. Besides saving lives. And then Hep B, rapid testing is pretty similar to hepatitis C, because the medications are much cheaper. And of course, with Hep B, you get immunization opportunities. I got my series right before med school and during med school. So it's really important to make sure everybody you identify is having unprotected sex or using IV, sharing needles to get them screened, and then make sure they're tapping into the community resources to have it treated. And that's extremely cost effective. Like I said, it was a short talk. I could go on and on. I don't know what direction people want to ask me questions on. I will be here till 4:30 today. I do plan, even though it's only going to be 74 degrees tomorrow, I do plan on coming back tomorrow as well. Probably stay till about 2 o'clock. So, you know, when you're talking about money, sometimes you don't want to say it out loud. You want to come whisper me questions. I'm happy to get whispered questions and answer them. And
Do you know of any OBOTs outside of the card ones that just have Medicaid, Medicare?
so the question was, are there other OBOTs outside the Carter Clinic that accept Medicaid and Medicare? And yes, the answer is yes. So there's several in Durham. And then there are private clinicians, even like Dr. Battle in my office accepts Medicaid and Medicare. But yeah, I think the challenge is that, well, I mean, I used to suggest people to go to Suboxone.com, which is, you know, Indivior, who recently gave $1 billion in settlement for inappropriate advertising. I want to suck into that, kind of. So I don't know that website is working very well right now because, you know, it's no longer branded. And I don't know that they want to use the name anymore. So you got to go to the physician locator. And the physician locator through SAMHSA will list pretty much everybody who has an X waiver And a lot of those folks aren't actually seeing patients.
Right.
So it's a big pain in the ass for the patient to go down that list and call when we find out that most people won't return their calls, which is why I'll always return calls. I get 3 calls a day, usually, even on Saturdays and Sundays where I don't have the kids. I will return calls and direct people, you know, in the right place that's gonna keep them, you know, that will start them and keep them there, and maintain. So, answer your question, I didn't get it. Oh, yeah, oh, so when they call down the list, they'll ask, do you take Medicaid and Medicare? That's like probably the #1 call that I get in my private practice. And so I call them back, and I'll say, okay, this is what I know. Carter Clinic, I think B&B in Durham, and Hope Center. Huh? New Hope Urgent Care, yep.
Bart,
Say again?
RII,
RII, so that's a new one.
that's a new one.
Okay, I haven't heard that. How long have you been open?
I'm not there.
Oh, you're not. RII, I haven't heard of that. That's great.
It's a large group practice across the United States. Recovery is doing something national, I think.
Mhm.
But they take Medicare and Medicaid. I know about them because I was the Durham during one of Dr. Joyce scheduled citywide on the policy. And they had a grand opening.
Oh, terrific.
And in our program, it makes detention facility.
In the Durham jail.
And
Okay. Sounds much nicer.
that's what I was told that it is. And
Okay.
also
Detained.
doing peer support specialist in the ER.
Yes.
So we had to find places for those patients to get medication. And most of them don't have insurance.
Yes.
Most of them.
Well, I know Bart is offering.
yes, Bart is,
Bard
that's
is-
correct.
Bard is providing.
She's talking about Recovery Innovations, RI.
Oh, yes. I know Recovery Innovations. Great program.
Yeah.
Yes. Browning's their medical
Yes,
director.
she
He's
is.
actually with
That's right.
Carolina Performance in my private practice. Yeah, Recovery Innovations, the Durham response, they're now doing like a 2-week bridge until they can find people in the community.
Correct,
And they've got some grant money to do that, and it is fantastic.
yes.
And Lincoln's still on.
Lincoln, yeah, Dr. Green in my private practice works in Lincoln. And she's fantastic. And I know that she mentors some of the other waiver physicians there, and very low cost, except Medicaid and Medicare.
Yes.
But that wasn't my question.
Oh, you had a question? I thought you were helping answering Ben's question. If you have another question.
I know that, you, on your slide, there was a really big range of cost in testing.
Yes.
So did you have to go and look at all of the vendors and then make a decision based on pricing? Is
Yes.
that- Yes.
I did look, okay, so, I am a big fan of Mako. I know somebody else, not that I have funding much, than primary sponsor, but, I like Mako, but when they started charging me for, all my confirmations and all my immunoassays, I did look at a number of other labs. And some of them did not even make an offer when they heard what Mako was charging because their rates were low. And some did make some offers and such. And I found that their prices were the best. And I fear change anyway. So, but if I found someone that was going to be cheaper, that would make it more affordable for all my patients, I would have gone with that. When we're talking about urine drug testing. And another thing is, you know, I give away or sell my $3 cups to patients and their families. Because if you go to a Walgreens or something, it's usually 40, 50 bucks for the same cup that I paid $3 for. And so, in terms of like observed compliance and peace of mind for the family members, I'll just hand them some cups or add on $3.
Sure. Could you talk a little bit more, you said when you do a cup and you get 14 positives, that what your thought process is for what you want to confirm? You said there's certain things that you jump on.
Right.
So what's your thought process?
So, yeah, so when I get a, yes, I'm gonna, so the question was, is when you get a cup and it's positive, you know, what is your thinking in terms of what to confirm? And what my thinking is oftentimes I always like to correlate the urine to the person. So I'm not, you know, I will put the cup in front of them and show them what they're positive for, because you're getting an instant reading and usually takes about 5 minutes to fully develop. And when they want to argue with their urine, I'm like, go ahead, there's your urine. You can argue with it. But let's talk about the results and why they might be positive. And if I get to kind of the bottom of things, then I don't always pay the money. I think when they're like, look, that cup is wrong. That cup is absolutely wrong. That's when I do confirmations. And that, sometimes that's billed to me, sometimes that's billed to the patient. You know, sometimes I'll just eat it, sometimes I'll make them pay for it, sometimes I'll go based on the result. So if it comes back and the cup was wrong and the patient was right, I'll eat it. If the confirmation is exactly what the cup said, then you're gonna pay the $35 that I have to pay. So that's kind of my thinking is I don't go based on just the cup. I gotta compare it and use it as gentle confrontation, or gee, you know, I like to play like Columbo, like, how did this get in here? You know, is somebody drugging you in the middle of the night? You know, somebody putting benzos in your sweet tea? What's going on at home? That's causing, because the benzo and the sweet tea thing, I think, is real. You know, so I mean, you play a little bit of Columbo and ask, you know, what's going on? But, you know, you can't argue with an aspect. An aspect is really the gold standard, and it gives me peace of mind. It informs the patient. You know, with mass spec, you also get, you know, a really good quantification. So you're not just getting a positive or negative like you are from the cup. I will give you nanograms per milliliter, which is really important information. Especially when their management changes because of the result. So typically in the OBOT setting, I will see you weekly. We'll go back to weekly. So you know, I might have somebody who's out 4 weeks and they test positive, so you gotta come back next week because something happened. And we need to tighten up treatment. And so I think people like me, and they like spending time with me, but they don't like paying me. And so, because I don't take insurance in my private practice, so, you know, I charge $300 for an intake and $130 for the follow-up. So that means you gotta pay me another $130, and they're not always happy about that. So, you know, getting that mass spec confirmation saying, look, I hear what you're saying this cup is wrong. Sometimes I'll pour the urine into a new cup and say, maybe it's the cup's fault. Well, this cup does the same thing. So, I mean, you can do that too, because that only cost me $3 instead of $35. So, you know, I'll do that, but, you know, after that, I'll do the mass spec confirmation and say, look, the lab's, this cup's wrong, and the lab is telling me you're completely negative, I'll pay for it. If you, then you pay for it. And I've maybe had, and it's usually benzos, a
Yes.
false benzo. Sometimes it's opiates, and it's a low-grade opiate that is still positive. At the lab, poppy seeds, I guess, if you eat a lot of poppy seeds, you gotta like break the seed open, right? With your teeth, swallow a whole bunch of them. That'd be a really good chewer. Because usually you just eat the whole thing and you poop it out, and the thing doesn't even open, you poop out the seed. But yeah, so I mean, that happens sometimes. And so at that point, you're like, well, I'll just eat the $35, that's fine, because I probably won't run.
I stepped out for a minute. Did you comment on the sort of regulatory expectations of background for how often and how much and all that?
Jim asked about the regulatory. Yeah, I talked a little bit about all the regulatory bodies that come into an OTP and how how costly that is for a lot of programs. Quite honestly, the preparation of those sorts of things.
I mean, in terms of doing urine
Urine drug testing in an OBOT or an OTP. So the OTP requires at least one urine drug test. Well, it's 8 a year is the federal minimum requirement, but it's really at least one a month. We'd like to do 2 a month. Back when we were getting them for free, we were doing 2 a month because if you got tested on the 1st of the month, you would know you couldn't be tested until the 1st of the month of the next month.
That's right.
So you would have 30 days where you could use and not worry about testing positive. So we'd like to randomize them to the half months. But now that we're paying for our urines, it is probably on a case-by-case basis. Some of my program directors are like, nope, I want 2 a month. I have too many high-risk patients, we're gonna pay for it. I'm like, okay, because I'm running it like a nonprofit, I guess. And so that's just what we're doing. While other program directors are more like, I'm fine with 1 a month. Typically, we'll do 2 a month for, especially the first year of treatment. And then once we get a better sense and more data points, we might drop to 1 a month thereafter. In an OBOT, typically I do urine drug tests for the first 6 or 7 appointments in a row until they pass several in a row for everything. Sometimes with marijuana, I might not test them every time. It's more of an art. I don't, in terms of the standards, I think once they're clean and sober, what is the standard? Is it quarterly, every 6 months?
Well, it's kind of why I was bringing up.
Yeah, it's not clear.
Is that, just to keep in mind as folks have this discussion about what kind of drug screening to do and confirmation, a lot of this stuff is just sort of expert opinion. In other words,
It's expert opinion.
So for example, there's no evidence from the literature that doing drug screens once a month or twice a month or 3 times a year, there's no evidence on what is an adequate, what's going to affect clinical outcome. I mean, we all kind of make judgments about that, as you just did, and yours are similar to mine and whatnot. But just to keep in mind that the standard of care, quote unquote, in terms of recommendation, is just that you do drug screens. And so the STOP Act, which passed some years ago for primary care or anybody else prescribing opioids, you're expected to do regular drug screens typically every 3 months if you're doing opioid therapy for pain. But OBOTs and buprenorphine is excluded from that. So if you're prescribing buprenorphine for opioid events, you're really going to have to adhere to the STOP Act. Then you're left with, well, what are the state recommendations? And they don't have any. So the state board, in its wisdom, has chosen not to implement any kind of regulatory standard around prescribing for OBOT. And so there are national guidelines, et cetera, but they're just that, they're guidelines. And so you really have a fair amount of leeway on, I'm gonna do cost and whatever else. I don't do that now, but you've got the option of doing point of care, and if you come up with what you think are reasonable standards on when you send it for confirmation. So like for example, I wouldn't send a cocaine positive for confirmation because the point of care is usually, if it says cocaine, it's cocaine. But I would send one for benzos, or I might send one for other things. So as long as you're making reasonable clinical judgment and getting the information you think you need, and as Eric said, for probably the biggest thing that's changed in the standard of care over the last number of years is that idea that you're prescribing buprenorphine at least some of the time, every once in a while, random or regularly, as you see fit, that you're checking for metabolite to make sure that it's not being, hopefully helping you know it's not being diverted. But you've got a fair amount of leeway to just sort of be sensible.
Yeah.
OBOS and OTBs, DEA will cut your tail off if you don't do your prescription.
That's right.
Oh,
Yeah, the
they tell you what
OTPs, you don't want to mess
tell
with.
you what to have in the drug screen.
Yeah. Well, I mean, so there are standards in what you have to test for. And, I think the state's going to add fentanyl, because I think they should. But for many years, you didn't have to test for oxycodone. And we know that that's, is a common abused opioid. And I think most of the clinics were testing for oxycodone, but there are a couple that weren't. And, and then you have a conversation with their medical director, and they're like, I don't feel comfortable giving take-homes if we're not testing for oxycodone. I said, add it to your test. Yep.
Oh, yeah, I have a question. For your Morris clinics, when when counselors are asking for retests of urine, are you seeing that it's more when they're benzo positive or with other substances?
So retesting is usually actually requested by the patient, not necessarily by
Right.
counselors. Yeah, I mean, I think because I run we call it benzo-free clinics, but they're not really benzo-free, we're benzo-light. We need patients where they are. So it's usually when somebody tests positive for benzos, and because of that, we do a very gradual taper, usually a milligram every other day, until they get down to 40, and their dose is reduced as triggered by the positive drug test, that they will contest the urine saying, no, that isn't a legitimate benzo positive, so then we send it for mass spec confirmation.
And how often when it comes back is it actually a false negative?
I would say about 20% of the time. A false positive.
Yeah.
Yeah. And then we'll take a month where we test everybody, because I'm looking for the Klonopin. And we've done that in clinics, and I'll only find like 1 or 2 Klonopin positives. I mean, it's really a really low percentage, because most people who are abusing benzodiazepines sporadically will test positive for something other than Klonopin in their use. Or they think they're buying Klonopin, and it turns out it's Valium. And so it pops positive. So it's pretty rare that we have a false negative benzodiazepine test. Yes.
How are you testing for alcohol? Are you, and we've had a secondary test that came back and it says it's for experimental use only.
Okay, so alcohol testing is really poor in urine in the alcohol screen immunoassay. So it's only going to pick up use within 4 to 6 hours after, before the test. So if you're testing at 9 in the morning, they would agree 3 a.m. and 9 a.m. to really pick it up. Now, the ETG, ETS tests, those are good tests. I don't think they're experimental anymore. You can hang your hat on them, and it picks up alcohol within 72 hours, pretty much, 48 to 72 hours. And, you know, again, you always got to correlate the result with the patient. What I really like about it is it gives you a level. So if it's a very low level, I usually give a pass to the patient. The other thing we do in our OTPs is we breathalyze. So if we get sometimes we'll get a false positive alcohol screen because the patient has diabetes or the urine sample's just been sitting in, you know, in 98 degrees weather and it ferments, and you get you know, sugar buildup, and the fermentation causes alcohol, and you're getting that on the screen. And so, you know, the nice thing about it in an OTP though is that you get to know the patients. They're coming daily. You know, you get to know them pretty well. And my counselors and my nurses can usually call which ones are false positives and which ones are false negatives based on their behavior. But if somebody tests positive on the screen, we'll breathalyze them, you know, daily for a week just to make sure they're not drinking. And then, you know, there isn't a consequence for a false positive.
Do OBOT patients have to get counseling?
Do OBOT patients have to have counseling? There is a requirement to be able to refer for counseling. And for a while, the state was, I don't know if mandating is they were insisting on you having some sort of agreement with a counselor, either in-house or out-of-house, that you could refer, some sort of MOA, BAA, and Gerald Peacock, with drug control, was asking for that actual document. And my answer was, I can always refer to my OTPs. Plus, I have a substance abuse counselor in my OBOT, solo private practice. So, so the answer is no, but you have to have the ability to refer and have a relationship with a substance abuse counselor of some kind. But I think if you have a good working relationship with an OTP, you're probably covered, because that hub and spoke model. So in our OTPs, we get a lot of folks asking for buprenorphine. We get them, we stabilize them, and once they're clean and sober, they realize, hey, I can probably get it cheaper and more easily by going to an OBOT. And that's perfect. You know, you can go ahead and go. If you relapse, come back and get the higher level of care that you may need. Because in an OTP, you dose daily, you see an individual counselor, and you're expected to go to groups. So it's a higher level of care. And so we like OBOTs that refer to us, and we will refer back to them, because we know that it goes both ways, and we're going to do what's best for the patient, not what's best for your senses. Does that make sense? Okay, so we got to be back by 2:45. So you got, you know, so the